Uh, Good morning, everybody, and welcome to today's presentation, Scan for Safety Wales, collecting today's information to answer tomorrow's questions. My name is James Griffiths. I'm a project manager working in value-based procurement, currently focusing on the introduction of Scan for Safety. My co-presenter is Andy Smallwood, Assistant Director of Procurement. Next slide, please.
Morning, everyone. Gosh, I'm not lying. Can you hear me? Yeah, okay, sorry. Morning, everyone. As James said, I'm Andy Smallwood. I'm the Assistant Director of Procurement at NHS Wales Shared Services and currently leading the Scan for Safety initiative within Wales. I've been involved with this side of things since around 2014, when we were just having a discussion with global standards, GS1, but just in relation to using barcodes within our warehouse division. And then that world came together with a project I was involved with at the Department of Health in England to start to look at the procurement strategy and how that could help with regards to procurement initially. And then a group was formed at the Department of Health, and quite quickly they saw that this wasn't to do with procurement. The main benefits in this area were to do with patient safety and the use of barcoding standards to try and help all of that. James and I are both also involved in value-based healthcare, value-based procurement, and presented at this event previously. And hopefully what we'll do, as the title of the presentation intimates, that we'll show you how this is actually linked into value. And when we saw the opportunities here, they basically pointed to outcome focused healthcare and how we could help with that. So I'm going to go through some of the linkages and the background, and then James, I'll hand back over to James for him to tell you where we're up to at the minute, and then we'll open up for some questions at the end. So back in 2016, the Department of Health in England put a pot of £12 million up to help 6 trusts pilot what they termed as Scan for Safety. And the basis of them was an organisation called GS1. So GS1 they license the issuing of barcodes to create unique identifiers. Next slide, please. I'll just give you a few of the acronyms that we may slip into while we're talking through this. So a GTIN is essentially the product barcode, as you'd see on any retail items. GSRN is the barcode standard for people, so essentially from where we're concerned, patients and staff. And then the GLN is the global location number that you essentially would have in a room, in a physical space. So next slide, please. In using all of these identifiers, the main aims of Scan for Safety are to make sure that the right patient gets the right product in the right place with the right process. And if I just give you some visualizations of what that could look like within or does look like within the healthcare setting, the next couple of slides we'll go through that. So next one looks at people. So all of our patients get wristbands. They're all able to have barcodes printed on them. They're not all currently in the same format, but that's work that's underway with DHCW to try and get to that point. But essentially a quick scan by clinical staff will identify that we've got the right patient. The next slide then shows you the type of barcodes that these are from Leeds, currently have this up and running. They were one of the pilot sites. So whether that's just an office door, a theatre or a storeroom, quite quickly we get a unique identifier as to where that is, so we can follow the patients and the products through the process. And then the next slide identifies that we've actually got some potential issues that we've historically had within procurement. So as product codes are not globally unique, there's an opportunity for duplicates, and there's 3 examples there of very different products, but actually the product catalogue number is exactly the same. So moving to GTINs, it means that any errors in relation to the wrong product turning up are basically taken out because of the uniqueness of the barcodes. The next slide then sort of shows some of the opportunities we've got in relation to using the barcoding to capture procedure types. Because we're capturing GSRNs, we can capture staff and patients involved in them, and then further down the line we're able to look at time in theatres, equipment used in theatres, and again to link them all together. So next slide please. Essentially this is what the essence of what we're doing is to try and bring in data standards so that we have a digital signal in the system that allows us to look at what was used, by whom, on whom, in what place and for what reason. And then the next slide, I suppose, is so what does that mean? Where do we start? Well, the key to all of this is data and data standards. This isn't just using a system, bringing it in, switching it on and making it work. We have to start to use the unique identifiers. They will be the breadcrumbs throughout the patient's journey to show all of the events that happen to them. And as I said at the beginning, the title is Collecting Today's Information to Answer Tomorrow's Questions. We don't know what tomorrow's questions are going to be, but if we can put all of that base data into the system now, we know that as soon as those questions are asked, that all of the information, however insignificant it may seem at the minute, will be there at our fingertips to try and inform better outcomes and any questions that we have. So in relation to making sure we've got the right tools for the jobs, we want to capture data electronically. The coding anywhere between 12 and 15 digits long, so we don't want those being transposed manually. And we need to make sure that the data signals we engineer into the system are as automated as possible. And then, as we're at a value conference, lots of Mr. Porter's words echo around all of this, and this one is definitely a good comment that captures what we're trying to do here, and which is to measure everything that we can. That will then allow us to analyze it, learn and improve. I'm 100% confident that this will take us into avenues and questions we don't even know we need to ask. So James and I have presented at this in relation to value-based procurement, and one of the frustrations that I have in that space is that the information that we've got with regards to procurement and product use isn't granular enough for where we want to go with regards to value-based outcomes. And I think that this really is a game changer and moves us along. I'm going to hand over to James now, who will give us an update as to where we're at, and then I'll see you again at the end of the questions.
Thank you, Andy. So if we consider in terms of the inventory management system where we currently are, it's fair to say that the current flow of products is fragmented and somewhat lacks transparency. Suppliers invest significantly in GTINs, as Andy mentioned earlier, global trade identification numbers, which are unique identification numbers for products that we don't make use of when they arrive either at the warehouse or the hospital or goods in. Suppliers have spent a significant amount of time and energy developing these numbers, and they're a useful resource that we're not really making best use of at the minute. So stock lines arrive at the shared services warehouse, at which point we disregard the GTIN and allocate another product code, which essentially adds another layer of complexity, and we're beginning to lose visibility at that point. Items can be ordered for direct delivery to hospital sites. When they arrive there, they require manual input. And again, we're lacking traceability and visibility at this point, not only in terms of having the same product with multiple product identifiers, but depending on the system being used, the delivery point could have several different location identifiers. We're not currently using what's called a GLN, global location number. So again, that adds complexity to the system and makes it difficult to track products across the supply chain. So a product progresses from a supplier, it perhaps into a warehouse or perhaps directly to a hospital. If it's a non-stock line, it's potentially required to be added manually to the system. Again, there's manual intervention there and a chance for transposition errors. When products do get used in the hospital, we have a lack of real-time information on what is used, when it's used, where it's used, and how frequently something is used. So, as I said, quite a fragmented and a system that lacks transparency at the minute. So valuable data is not currently being collected, and the range and depth of information shared is limited. It does not extend the length of the supply chain from order through to delivery to point of use. You can see these different silos within the system. Certain products such as implants are then placed in patients. So we get to beyond the point of consumption, perhaps in a theatre. But the recording here is very manual and tends to be paper-based, making both traceability and recall much more difficult and time-consuming. So at each step in the situation, we're not making use of GTINs, we're not making use of global location identifiers. We have these sort of fragmented, lack of transparency, data collection, lots of manual entry, all of which adds up to us getting a very poor picture of the end-to-end supply chain, where goods are, who's using them and who they're being used on. So the key message here, currently, there's a lack of inventory control. We have multiple product entry points and we tend to lose track of what's happening and where. There's lots of manual processes, especially around the input of batch and expiry dates. We really need to collect those in an electronic way. We have multiple identifiers for a single location or a unique product. So we need to progress from this relative chaos to somewhere where we have relative control of inventory. Next slide, please. So as you can imagine, this is not just a system change. We've been working like this for years. It's more, along with changing the system, there's a deep-seated cultural change and challenge ahead of us. Next slide, please. So if we look at where we would like to get to, so our primary objective is really to have the right product, the right place at the right time. As I said in the previous slide, we're lacking the basic signals and granular detail needed to be able to answer those fundamental questions. If you were to ask us now how much stock do we have, we could give you an idea, but we couldn't say with confidence how much stock we've got end to end within the supply chain. Where is the stock? Again, without standardized data signals of product in place through the supply chain, it's difficult to tell you exactly where all our stock is. How long will it last? With current manual input of batch and expiry dates, that's not captured in a standard way across the system. So we may not really be best placed at the moment to tell you exactly how things will last and be able to manage things based on use-by dates. Are we able to tell you if our locations of consumption are under or overstocked? We've got an idea, but we couldn't say with confidence across the supply chain. Is all my stock in date? Again, we need to get a better handle on that. Where and when was it last used? How much are we using per location? Again, all these signals that we need to collect to get a better understanding of the end-to-end flow of our products. So this is where we hope to get to. So with the GTIN becoming a primary product identifier, the point of order through to the delivery, combined with the GLNs as unique place identifiers, we start to build this end-to-end visibility from order to delivery at warehouse, and then consumption and use on the patient. So you might remember in the last slide, the information and the flow of demand and information and data was quite fragmented. and it wasn't really end-to-end, but here, through the use of scanning technology, the standardization of GTINs, GLNs, and the GSRN, as Andy previously mentioned, we hope to build a system that allows information to flow from the point of entry to the point of use, and this data we can use to better understand what's happening within the supply chain. So with transparency and data further enhanced with the use of the GSRN, unique identifier for patients, the combination of the GTIN, GLN, GSRN and scanning technology will allow us to better understand who used what, when and where. Then with the use of API technology, we can then start to link these data signals for product, place and person to such areas as the National Data Resource, the Medical Devices Information System, to really start to build a more powerful picture and understanding of what's happening across the supply chain and the cycle of care. Next slide, please. So progress to date. A full business case was approved and noted by the Minister of Health and Social Services. Welsh Government and NHS have agreed a funding package of 2.25 million capital funding with 5 million of revenue funding over 5 years. We've become members of GS1 and work is underway with DHCW to adopt the relevant standards. And we're currently defining processes for optimal GS1 identifier location management. Our Oracle system is has been changed to facilitate GS1 coding. And in terms of the inventory management solution, a tender was undertaken and awarded to Omnicell, and we'll be working with their SupplyX system. In terms of implementation timelines, contract started in September 2021 with SupplyX, and we have the target of introducing SupplyX inventory management system into 1 theatre or lab per health org by the end of March 2022. And then we intend to grow at pace from there to all theatres and all labs in all health orgs by the end of December 2022. So some challenging targets, but we believe they're achievable. Next slide, please. So an overview here of the benefits and how they might link to value in health. So the overarching benefit and the real reason for doing this is one of patient safety and improved outcomes. So the prevention of never events, and a never event is seen as errors in medical care that are clearly identifiable, preventable, and serious in their consequences for patients. For example, product safety alerts or scanning will help us identify products that really should never reach a patient. Swift product removal following alert. We'll have the ability to scan a product before it arrives in a patient with linkages to various databases. We should have the ability to identify any products that might be subject to a recall, so they're not progressing anywhere near a patient. So patient safety really is paramount, and improved outcomes are really at the heart of this scamper safety activity. In terms of efficiency across the cycle of care, well, we hope to reduce lost clinical time to administration. Clinicians are currently spending several hours a week managing paper-based orders and looking for stock information. Well, we hope to get to a point where those several hours become minutes, if anything, allowing nurses and clinicians to work at the top of their license. Okay? SupplyX should bring with it automated ordering and reporting, which will facilitate those tasks. We expect to see a reduction in urgent orders. If we've got the right stock in the right place, then we're optimizing our stock holding. Also, with the automatic capture of expiry dates, batch numbers, etc., scanning of the batch and expiry dates combined with reporting capability should see a reduction in stock obsolescence and waste. And we're also expecting to see some improved theatre uptime, fewer cancellations because we've got the right product in the right place. Automated ordering, even linked to future demand, should mean that we optimize our stock holding and reduce ordering just in case, and start to move to more of a just-in-time situation. From a finance perspective, we should have more transparency of unwarranted variations, and associated savings should flow from that. In terms of PLIX and TDABC, there's an opportunity to build and automate cost and data capture, further linking that to the patient and procedures. Granular data signals captured across the cycle of care, linking product, place and person, as I mentioned earlier, can be a really powerful tool for our finance managers. And legally, of course, there's the Medicines and Medical Devices Act of 2021, which is a legal imperative to digitally link implantable products to patients. The Senate has agreed to comply with this in February 2021, so this system will allow us to do that. And we will be collecting data to inform the Medical Devices Information System, which will be live in 2023. So in summary, the real reason for doing this is patient safety and improved outcomes, but there are some efficiency gains that flow from that. Next slide, please. So there's also, and you would have picked up on this through the previous slides, but there's one of data focus. So implementation of GS1 standards for product, place, patient, and procedure identifiers should, the introduction of these robust, unique identifiers should reduce ambiguity and move us towards a system where we're able to share information with confidence. We should have common standards to facilitate easier system integration. Fewer ordering errors, more accurate receipting, again a batch, serial and expiry date captured in a single scan, no more manual entry. As you start to collect that data, we have improved analytics based on real-time data across the cycle of care. And we've started to build then a more and more granular data that will be collected to help answer the questions of the future. And as Andy alluded to, and Michael Porter has often said, if you do nothing else, measure, measure, measure. Next slide, please. Okay, so the key message behind this slide is we're at the top left-hand corner of evolution. Standardizing and normalizing our use of core standards and enablers such as the GTIN, GLN, and GSRN, combined with scanning and inventory management. These are the core enablers that we're working to get in place. But the real benefit comes when the data signals we've collected can deepen our understanding of what products are being used across the cycle of care, by whom and by when. Linking these signals to patient outcomes will really start to contribute to offering improved value in health. But the systems on the right only really start to offer maximum benefit when the standards on the left are adopted. Until then, there's opportunity for misinterpretation, and as you've seen, we've got quite a fragmented supply chain and sharing of information at the minute. So standards on the left, progressing with efforts through NWSSP, efforts within the health board, and combined efforts from all of us to maximise the benefits on the right as we start to really build data and valuable information on what's happening within the system. So to see how this aligns with value in health, if we could move to the next slide, please. So we think Scan for Safety is helping to deliver the value in health vision, namely a data-driven system, timely information, informing improved decision making, and if we can link the signals along the cycle of care to those of patient outcomes, we're really starting to help deliver the vision of value in health. So if you want to find out more about the Intelligence for Value framework, bringing data to life, the session tomorrow at from 1 to 2:30, the speakers will be Dr. Alan Mordor, Navjot Kaura, Chris Haverley, and Ian Bell. Really recommend tuning into that session. So I think I've reached the end of the presentation. We'll now move. Thank you for listening, of course. We shall now field some questions. If you don't have time or the opportunity to field a question, then please contact us at the email below. Any questions that we can't get to, obviously we'll endeavour to answer those after the session, but we should have 10 to 15 minutes now for Q&A. Okay, so quite a few questions coming through for Andy. First question. The investment looks great, but what level of return have the pilot sites recorded?
Look, I saw that on the chat just before you came live. I just opened there's a report from GS1 that was published in 2019 that looked at the pilot sites. There's 3 headline figures in there, and I'll give you the reference of the report. Is called a scan of the benefits, scan for safety evidence report. So the 3 main headlines there are in the 3 or 2.5 years to when this was published from the pilot sites, released 140,000 hours of clinical time back to care from admin tasks, 5 million of recurrent inventory savings, and 9 million of non-recurrent inventory savings. So if you put that in context with the 12 million investment that was made, the payback was well within 2 years. So I think that there's some good evidence in there that you should do this from a finance perspective anyway, but actually that's not the real story. The real story is patient safety. But yeah, so hopefully you'll be able to go and dig into that report. It's got lots of good examples in there around how it feeds in with the different specialties as well. So there we go. Okay.
Thank you, Eddie. Interesting one here. Do you plan to scan everything or just theatre products?
I'd love to scan everything because if I don't like to compare retail to the NHS because they're nothing like each other. But in the retail sector, we know where every single can of beans is. We should know where every product is in the NHS. The scan for safety program, we're focusing on theatre, lab, cath lab, anywhere where an implant into a patient would take place. That's the initial focus. However, in parallel to that, we're also introducing it to our materials management within the shared services warehouses and the flow of goods into the health boards from there. Some of the pilots, well, so one of the sites in England that wasn't a pilot site is Hull in East Yorkshire Foundation Trust. They've rolled this out quite extensively and have actually got it out in the community, looking at patient homes, looking at aids for daily living going in and out of there. And in the current markets, there's some pressure in the supply chain of patient aids. So they've got a really good handle on who's got what where and whether they're still required. Also gas bottles and things like that. So whilst our initial focus is theatres, the opportunities go way beyond. And I think, as James said, once we're through the first round of theatres across Wales being implemented, I think that this will start to expand quite rapidly.
Thank you, Andy. Okay, so how do you plan to link the information to patient outcomes? Okay, so
I think the answer is we don't. But and the reason that I explain that is that the scan for safety is the data capture, and as James explained in one of the slides, that's the way that we've tendered and awarded the contract is that it then has to interface with existing systems via API technology or standard. So from our perspective, this is the data capture that then interfaces with existing systems and other systems, so that we're not introducing a new way of doing things and people have to stop using their current systems and use this one. So Alan Ward, or as James said, give a plug for his session tomorrow, was on our project board, and I was educated early on in the project that the system needs to interface so that it feeds the data signals to where they need to be. The national data resource is obviously going to be critical to this, and hopefully that what we're introducing with regards to scan for safety will be the data capture mechanism that flows right the way through that into there.
Okay, just scanning the question. Okay, so we got one more question. Do you think there is an opportunity to link this to health technology assessment processes so that we understand how new medical devices really perform after they are adopted? Good value focus there, I think.
Absolutely. I mean, off the back of Cumberledge reports, 3M capital hip, PIP breast implants, there's a number of times in the past where the problems have occurred and not been spotted early enough. Black box thinking is a great way of describing it. We know everything that happens to airplanes, to other things, but we don't capture the right amount of data to do with what we do with patients. I think with regards to new medical devices, as I said, the scan for safety will capture all the data signals. I then think that we then need to work with each of the health organisations to make sure that feeds the right patient data, feeds the right outcome data, because scan for safety isn't the whole story. It's a real boost to the value in health story, but I think it's also, it's a good point. It's very, very useful for medical device assessment. We will get early indicators of any problems. So yes, is the answer.
Thank you, Andy. Okay, and another question. Thank you for this. Would it include items such as surgical trocars and lines, or just surgical implants?
It will include everything that's scanned. So within the theatre lists, we'll capture all of the products that are used. So from the supply X, it has the ability to link all of the product scanned to the patients. I think within each theatre there's going to, and this is going to be the interesting side of things. So I think as a trocars and lines, I think yes, we should. What pair of gloves and what gown the surgical teams are wearing, I just think not, but it's all still in the system. We just need to make sure from that perspective there are enough consumables in the right place to facilitate the procedures. And then with regards to all of the different scanned items that are linked to patients, the more granular we can go, the better. I think anything that will influence the outcome of a procedure should be scanned and linked to the patient, because it might be the best implant in the world, but if it's put in with the wrong instruments in the wrong way, then it's not going to perform how it was intended. So my answer would be it's possible, and I think as each theatre goes live, there's opportunity to work through that and make sure that they are.
Thank you, Andy. Okay, so another question. If the primary objective is theatres and labs to capture implants, when will interventional radiology be added?
I think early on. I mean, it's interesting that our original targets were one theatre per org, but some of the initial discussions that we've had, we're working with Brongleis Hospital, who want to do 5 theatres, ICU and an endoscopy suite. And that sounds a lot bigger than what was originally planned, but it's smallish in the hospital and compared to some of the ones we've got in Wales. And the product flow goes through some combined stores, so it makes sense to do that. So the intention is that we roll this out as far as we can. I think interventional radiology I would probably tag alongside labs, but it can be scanned, but those products do need to be tracked. So the answer would be, I'll need to plan that in for the rollout during 2022.
Thank you, Andy. A couple more questions coming through. Okay, so will there be linkage and learning with the pilot sites to ensure any learnings in both areas are shared? The best for healthcare is key.
Short answer is yes. We've there's a healthcare user group that exists that we've been invited to sit into. With it's chaired by the Department of Health in England, but as now involves the developed nations. Some are doing it slightly differently. Northern Ireland, sorry, are doing it, introducing scamper safety in a different way. They're using theatres systems rather than a scanning system. But absolutely, as I mentioned before, the information I got around Hull and East Yorkshire, around where they've extended it out, has came through that forum, so that we can we're picking up new opportunities. And also it will inform us with regards to future investment and where we need to focus. We've just been through hopefully not been through it completely, but with regards to the pandemic in the last two years, all of this information, it was at our fingertips, would have helped in relation to making sure that we've got the right products in the right places for everyone. And I think from the healthcare user group, lots of use cases are shared around how people have done things differently, how they've managed it, and how this impacts. Because as James showed in one of the slides, this isn't just drop a fancy gadget off and expect it to be switched on and used. This is a big culture change. We're moving from theatre records that are, in my memory, have been involved in the NHS when I started out, a big stack of books in the corner with lots of little stickers in them. But to something that's at our fingertips to allow us to inform analysis. So yeah, absolutely, and we'll be sharing our learnings back to that group. Within Wales, we've got the benefit of the Value in Health programme. I think that's ahead of the game with regards to thinking across the UK. We've also got the bonus of a national Oracle system, so our finance purchase to pay system is consistent across all orgs. So therefore, our interfacing with that is a lot easier, and also we've got a national data resource. So I think a lot of whilst we are starting on this journey with regards to scamper safety a few years behind the pilot sites, I think that the broader context and the broader thinking is actually ahead of that, and hopefully we'll be able to accelerate with the lessons we've learned from there, and then share back to the other nations how this links in with Value in Health, and what are the benefits they can have out of it.
Thank you, Andy. Very complete answer. I think we've addressed all the answers, all the questions, sorry, that I can see there. So just double checking. Yeah. So if there are any more questions, please feel free. Okay, so we got time for one more. I think I can see something whirring away. As I said in one of the finishing slides, I know this presentation will be shared, so if you do have any further questions, please don't hesitate to contact us at the Scamper Safety Wales email. I don't believe there are any more questions coming through, so it remains for me to thank you for joining today's session. I hope you found it informative and useful. Thank you to Andy for answering some of the questions there, really in some great detail. And please don't hesitate to reach out to us if you have any further questions. Thank you for listening.